Hello everyone, myself Dr. Omkar Sangita Dilip, and today I welcome you all back to the session of Sparks by AFMG. So in today's Sparks session, we'll be discussing about the pathology in the respiratory system. We'll be revising all the important points, all the high-yield topics and every other pulmonary disease that has come in the exams previously, okay? So all the frequently asked questions will be discussed in today's sessions. Today's session will also be in a retrograde fashion, okay, where we'll be discussing about the MCQs and then we'll move on to the actual topic. So let's begin without any further delay with today's session. So before beginning our today's session, I would like you all to go through this quote which states, if you are willing to put in efforts, no one can help you. If you are determined to put in efforts, no one can stop you. So please remember guys, if you are really determined towards your studies, towards your goal, no one and no situation is going to stop you. So let's begin with today's session. So before starting, I would like you all to actually start with the introduction about your pulmonology. So please remember, we'll be discussing some important points in pulmonology first, okay? So the important point that I will discuss over here is the normal lining of your respiratory tract. So the normal lining of your respiratory tract is made up of which epithelium? This question has come earlier, okay? So please remember, the normal lining of your respiratory epithelium or respiratory tract is made up of pseudo-stratified ciliated columnar epithelium. So please remember guys, the normal lining of your respiratory tract is made up of pseudo-stratified, okay? It means it seems like there are many layers, okay, but there is only a single layer. So it is pseudo-stratified ciliated, which has cilia, columnar epithelium. Because columnar epithelium, because it produces mucus, okay? So mucus is secreted. That is the reason why the normal lining of respiratory tract is pseudo-stratified ciliated columnar epithelium. The next point I would like you guys to remember is from physiology, but the questions has come earlier also, and it is about your Weibel's classification. So please remember, the Weibel's classification of airways is very much important, and the Weibel classification of airways divides the airways into various generations, where generation 0 is your trachea and generation 23 is your alveoli. Okay, so please remember, generation 0 is your trachea and generation 23 is your alveoli. In between, generation 1 would be your primary bronchus, generation 2 your secondary bronchus, and further on it is divided. Okay, the important generation that you need to remember is your generation 16. And why is generation 16 important? Because please remember, generation 16 are your terminal bronchioles. What is generation 16? Those are your terminal bronchioles. Whereas generation 17 is also important, and generation 17 are your respiratory bronchioles. Generation 17 are your respiratory bronchioles. So important one, okay? So just remember guys, generation 0 to generation 16 would be your conducting zone. Please remember, these are your conducting zone. That is, the air is only conducted, okay? No exchange takes place between generation 0 to generation 16. Whereas from generation 17 onwards till generation 23, the actual exchange or respiration occurs, okay? The actual exchange or respiration occurs in the generation 17 onwards. Therefore, generation 17 to 23 would be known as your exchange or respiratory zone. This is important to be remembered. Then the next point that question can be asked on is the maximum amount of smooth muscles are seen in. So please remember, the maximum amount of smooth muscles are seen in your terminal bronchioles. Please remember, maximum amount of smooth muscles are seen in your terminal bronchioles, and therefore the bronchoconstriction or bronchodilation, whatever occurs, that occurs mainly at the level of your terminal bronchioles, okay? After that, from respiratory bronchiole onward, there is only a single lining of the epithelium which facilitates respiration, okay? So important ones. So these are the basic points about respiratory system that you guys need to know from physiology also and from anatomy also, okay? Now let's move on to the next important question of physiology that on which questions have come earlier, and that question is about pneumocytes. So please remember, the respiratory cells are known as pneumocytes, which are mainly of two types, type 1 pneumocytes and type 2 pneumocytes, okay? The important question would be about the function of these type 1 and type 2 pneumocytes. Type 1 pneumocytes are responsible for what? Yes, they are responsible for exchange. They line the alveoli, and therefore they are only responsible for exchange of gases. Whereas type 2 pneumocytes has two important functions. The most important being your surfactant production. The most important function of your type 2 pneumocytes is what? Surfactant production. As we all know, surfactant maintains the surface tension, therefore it prevents the alveoli from collapsing. Okay, it keeps the alveoli patent, because that the exchange can occur easily. Okay, so please remember, surfactant production is a function of type 2 pneumocytes, and this question has come twice. Okay, important one, many a times in earlier exams. Apart from that, the most important second function of type 2 pneumocytes is repair. So any repair that is undertaken in the respiratory system is the function of type 2 pneumocytes. Okay, important two things that you need to remember. Now let's discuss about pathology. So before discussing on pathology, just see the classification about the pulmonary diseases or the lung diseases that we have. Okay, so the basic classification that we have, it is your first group is your OLDs, that is your obstructive lung diseases. Okay, so obstructive lung diseases are due to some obstruction or some pathology in the airways. Okay, in the airways of the respiratory tract itself. Okay, so the examples of obstructive lung diseases would be what? Please remember, the examples of obstructive lung diseases are your asthma, bronchial asthma, chronic obstructive pulmonary disease or COPD, and some diseases like bronchiectasis. Whereas the next group of diseases is your RLDs. Okay, RLDs are your restrictive lung diseases, where actually the respiration would be impaired due to the inability of lungs to expand properly. Okay, and that is, there is some restriction. Okay, it is due to some basic pathologies, like first of all ILDs. What are ILDs? ILDs are your interstitial lung diseases, where the pulmonary parenchyma or the lung parenchyma is actually affected. Okay, so there is fibrosis seen mainly in cases of restrictive lung diseases. So first are your ILDs, interstitial lung diseases. Then are your pneumoconiosis. What are pneumoconiosis? Those are your occupational lung diseases like silicosis, asbestosis, anthracosis, etc. Okay, next can be your chest wall diseases. Okay, so chest wall diseases or rib cage pathologies also come under restrictive lung diseases, and some other diseases which are associated with some other condition, like for example in congestive heart failure there can be pulmonary edema or cor pulmonale. So please remember, pulmonary edema or cor pulmonale also comes under restrictive lung diseases because the exchange is impaired. In cases of obstructive lung diseases, the exchange is normal. Okay, there is no impairment of function in the exchange of gases. Whereas the last group of diseases from pulmonary pathologies is your pleural pathology. So please remember, pleura is the lining of your lung. Okay, the outside lining of your lung. So the pleural cavity pathologies can be something like pleuritis, where there's only inflammation of your lung. Okay, there can be some pleural effusion. So these are your basic classification. This is your basic classification about all your lung pathologies that you have. Now let's move on to the actual questions, guys. So the first question that you have, a 40-year-old woman presents with recurrent episodes of breathlessness and chest tightness. On auscultation, bilateral wheeze can be heard. The microscopic examination of sputum shows the characteristic finding in the given image. What is the most likely diagnosis? So this is your sputum examination. So please remember, the image which is given, it is of sputum microscopic examination. And what are these black arrows showing us? So please remember this, black arrows are showing us some bodies. And what are these bodies? So let's discuss this. Okay, so please remember, guys, this is a classical case of a 40-year-old woman presenting to the emergency with recurrent. Okay, recurrent means back-to-back episodes of breathlessness, that is shortness of breath. Okay, and there is also chest tightness. It is due to excessive mucus production. On auscultation, bilateral wheeze can be heard. So wheezes are usually characteristic of which type of diseases? So please remember, wheezes are usually characteristic of obstructive lung diseases. As there is some obstruction, therefore a whistling sound, a wheeze can be heard. Okay, so it is an obstructive lung disease. Now we have narrowed down our thinking to OLDs. So now let's discuss that further. The microscopic examination of the sputum is showing the characteristic finding. And what is this characteristic finding? I have told you these are some bodies. But what are these bodies? So please remember guys, these cylindrical bodies are nothing but your creola bodies. Okay, so please remember, these cylindrical bodies are nothing but your creola bodies. Okay, and what are creola bodies? Creola bodies are your shedded epithelial cells. Okay, so please remember, creola bodies are your shedded epithelial cells from your respiratory tract. And what are creola bodies most characteristic of? They are most characteristic of your bronchial asthma. So the answer over here, the most likely diagnosis in this condition would be option B, that is bronchial asthma. So let's discuss few points about bronchial asthma that you need to know. And as we all know, bronchial asthma is a very common disease that we encounter usually every now and then in the emergencies. So it has always remained a hotshot topic for your examiners too. So please remember, now we'll discuss about bronchial asthma. So what happens in bronchial asthma? Bronchial asthma mein there is reversible bronchoconstriction. Important point. The definition is itself important. So please remember, in bronchial asthma there is reversible bronchoconstriction due to some allergen exposure. So please remember. Okay, let's see the definition first. It is reversible, means as soon as the allergen exposure is stopped, okay, the condition would reverse to normal. So it is reversible bronchoconstriction, that is, there sudden bronchospasm which is causing this respiratory distress. So reversible bronchoconstriction, it is due to some allergen exposure. And I have always told you, due to some allergen exposure, if there is some allergic condition, it is which type of hypersensitivity? So please remember, it is type 1 hypersensitivity. So bronchial asthma comes under type 1 hypersensitivity. Okay, important one. I'll be discussing just important points about bronchial asthma in this topic. Okay, so please remember, the next important point for your examination would be the most common gene mutation associated with asthma. So please remember, the most common gene mutation which is associated with asthma is what? It is your interleukin 13 or IL-13 gene polymorphism. So please remember, the most common gene mutation associated with bronchial asthma would be IL-13 gene polymorphism. Important question. The next question that can come from this topic is your most important cells. Okay, so please remember, the most important cells in bronchial asthma. And which are the most important cells in bronchial asthma? Please remember, the answer should be mast cells. Okay, so as we all know, okay, due to some allergen there is mast cell sensitization, and as soon as the mast cells are sensitized, they degranulate, and as soon as they degranulate, they release histamine. Okay, so please remember, mast cells are the most important cells in early phases of the disease. So please remember, in early phase of bronchial asthma, mast cells are most important. Whereas if the question comes, which are the most important cells in the late phase of bronchial asthma? So the answer would change. In late phases of bronchial asthma, the most important cells would be eosinophils. Okay, the most important cells would be eosinophils. Important one. Next question can be the most important T cells. As we all know, T cells mediate this reaction. So the most important T cells in cases of type 1 hypersensitivity or in cases of bronchial asthma. So which are the most important T cells in type 1 hypersensitivity or bronchial asthma? Those are your type 2 helper cells. So please remember, the answer would be type 2 helper cells. Important one. Next one. The next question can be the most important chemical mediator. Which is the most important chemical mediator in cases of asthma or type 1 hypersensitivity? So the answer over here should be, as we have studied earlier, mast cells degranulate, and which chemical mediator they release? They release histamine. So please remember, histamine is the most important clinical chemical mediator in cases of asthma, followed by leukotrienes. Okay, the most important one is histamine, followed by leukotrienes. Okay. Whereas if the last question they ask about most important ones, that the most important immunoglobulin responsible for asthma. So the most important immunoglobulin in cases of bronchial asthma or in cases of any allergic reaction would be immunoglobulin E. So please remember, immunoglobulin E is most important immunoglobulin in cases of allergic reactions, whereas IgM is for acute infection, IgG is for chronic infection, and IgE is for allergic reactions. Okay, important one. One more question from pathology about asthma that can come is, as we all know, for isotype switching. Okay, for isotype switching of antibodies, what happens usually? IgM is located on the cells, okay, and this IgM is converted to IgE, and this conversion is known as your isotype switching or class switching. And which is the interleukin which is responsible for this class switching? So please remember, interleukin 4 is very much important, okay. So please remember, interleukin 4 is the most important interleukin which is responsible for isotype or class switching in cases of bronchial asthma, okay. This is very much important, guys. Now let's talk about some few important points from pathology, okay, for our bronchial asthma. If we perform a microscopic examination of sputum, okay, if we collect the sputum and we perform a microscopic examination of sputum in bronchial asthma, what are the three characteristic features seen? So please remember, you will see 3 C's. And what are these 3 C's seen? And those are very much important. First C is your Cushman spirals, okay. The first C would be your Cushman spirals, okay. These spirals are seen in your mucus plugs, okay. Second C is your Charcot-Leyden crystals. Second C is your Charcot-Leyden crystals. And what are these Charcot-Leyden crystals? These are needle-shaped crystals which are made up of galactin-10 protein. Important one, please remember. These are made up of galactin-10 protein, okay. So Charcot-Leyden crystal is the second C. And the third C which is seen in microscopic examination are your Crayola bodies that we have already seen, okay, in the last picture. So please remember the 3 C's which are seen on microscopic sputum examination of bronchial asthma. First is Cushman spirals, second is Charcot-Leyden crystals made up of galactin-10 protein, and third is Crayola bodies which are shedded respiratory epithelial cells, okay. 3 important C's that you need to remember. Whereas also you need to remember, if we take a biopsy of the airway, okay, if we take the biopsy of the airway in cases of bronchial asthma, in these patients, what are the 3 features that would be seen on biopsy? So please remember, the first feature is seen as your goblet cell hyperplasia, okay. So please remember, asthma kaise yaad rakhoge? Asthma can be remembered easily, okay. So in asthma, what happens? There is a minimal stimulus, but the airway reacts in an extreme manner, okay. The airway hyper reacts, okay. That is the basic pathology in asthma. Airway hyperreactivity. So there is goblet cell hyperplasia. As there are more number of goblet cells, excess of mucus production is there, which causes this obstruction, okay. Second is what? The second feature that you would see is your smooth muscle hypertrophy. Again, this is also responsible for your obstruction. What happens? As this hypertrophied smooth muscle undergoes bronchospasm, there is more respiratory distress. So second feature is your smooth muscle hypertrophy. And third is your subepithelial increased collagen. The third feature is your subepithelial increased collagen. And these 3 features together on a biopsy of your airway in bronchial asthma is known as your airway remodeling. These 3 features are known as airway remodeling. So please remember, airway remodeling is seen in cases of bronchial asthma, and the 3 features are goblet cell hyperplasia, smooth muscle hypertrophy, and subepithelial increased collagen, okay, important ones. Whereas I will just tell you about how to treat the asthma attack. So as we all know, asthma is more prominent when it is more predominant in night, okay. So therefore the patient would present to us in night in the emergency, okay. There would be nocturnal episodes of asthma, and an episode of asthma is treated with what? An episode of asthma would be treated first of all with oxygen supplementation. Along with that, we give IV salbutamol. And what is salbutamol? It is your beta 2 agonist. It is a short acting beta 2 agonist, SABAs, okay. So SABAs like salbutamol or terbutaline are given, okay. So important ones, okay. Please remember how it is treated. So SABAs can be given, okay, short acting beta 2 agonist. Along with that, we can give corticosteroids, okay. Corticosteroids are always given, okay. And the important points on which question have come, I'm just covering some part of pharma over here. So please remember, guys, in cases of asthma, there is a monoclonal antibody. Question has come on this. Please remember, this is very much important. A monoclonal antibody against your immunoglobulin E, a monoclonal antibody against IgE, which is used in cases of asthma, is what? The drug name is omalizumab. So please remember, guys, the monoclonal antibody used in cases of bronchial asthma which is against the immunoglobulin E, it is your omalizumab. The next question that has come is which has been twice repeated. It is your about the drug which is used in cases of asthma, which is 5-LOX inhibitor, okay. So please remember, 5-lipo-oxygenase inhibitor drug used in cases of bronchial asthma is your xylutone. It is your xylutone, okay. Another drug that is important is your mast cell stabilizer like sodium chromoglycate, okay. These are the important features that you need to remember about asthma. This is all, okay. Moving further to our next question, guys, okay. All the below given statements are true for interstitial lung diseases except. Now let's discuss about some OLDs, some features about OLDs and some features about RLDs over here, okay. So let's see what are the features, okay. So we are talking about interstitial lung diseases, which is an example of restrictive lung diseases, right? First question is option A, diffusion capacity is reduced. As we all know that the exchange or the respiration is impaired in cases of restrictive lung diseases. Okay, there is impairment in the exchange, therefore the diffusion capacity is reduced. Okay, it can also come as DLCO, that is diffusion capacity of the lungs for carbon monoxide. Okay, so diffusion capacity of the lung would be reduced in cases of interstitial lung diseases, therefore this statement is true. Second, option B, honeycombing pattern is seen on HRCT, that is high resolution CT scan chest. So please remember, in cases of interstitial lung diseases, due to the interstitial fibrosis which is there, we can see a honeycombing pattern. Okay, we can see something like this, the honeycombing pattern on HRCT chest. So this statement is also true. Next one, option C, fibrosis may or may not be seen. So please remember, yes, in cases of interstitial lung diseases, it is not always that we will see fibrosis. Okay, so fibrosis is usually seen in the late stages of the disease. So fibrosis may or may not be seen. This is also a true statement, and we need to find the false statement. Okay, all are true except. So option D is the ratio of FEV1 to FVC is reduced. So please remember guys, the ratio of FEV1 upon FVC. Okay, what is this? FEV1 is your forced expiratory volume in your first second. Okay, so forced expiratory volume in first second, it is usually decreased in cases of your obstructive lung diseases. So please remember, FEV1 is reduced in cases of obstructive lung diseases, whereas FEV1 is absolutely normal in cases of restrictive lung diseases. There is no problem in expiration, there is no blockage, there is no obstruction in RLDs, therefore FEV1 is absolutely normal. FEV1 by FVC ratio would also be decreased in cases of obstructive lung diseases, okay, and not in cases of restrictive lung diseases. So please remember, FEV1 by FVC ratio in restrictive lung diseases would be absolutely normal again. Okay, the only volume that is decreased in cases of respiratory lung diseases is your forced vital capacity. So FVC is the only one which is reduced in cases of restrictive lung diseases. The forced vital capacity is decreased. Okay, so please remember this. So answer to this question is option D. The ratio of FEV1 by FVC is reduced in cases of obstructive lung diseases and not in cases of interstitial or restrictive lung diseases. Okay, moving on to our next question guys. Now the question states, there are two patients, Ram and Shyam, who present to the respiratory OPD with complaints of cough, dyspnea, which is progressing. Ram is an auto-mechanic by profession, and his examination revealed calcified pleural plaques on imaging. And Shyam is a minor by profession, and his chest X-ray revealed eggshell calcification. Okay, important one guys. So Shyam's X-ray is revealing eggshell calcification. Which among the following statement is not true? We need to find the false statement. This is very much important. Always read the last line carefully. Now, the first statement goes option A, Shyam is more likely to develop tuberculosis. So let's come to a provisional diagnosis in our mind. What can be there? Okay, so please remember, both are presenting with cough and dyspnea. Okay, and you specifically their profession is mentioned, so definitely it might be related something to their profession. So it is a occupational lung diseases that they are talking about. Okay, so they are mainly talking about your occupational lung diseases or your pneumoconiosis. So we have narrowed down our thinking to pneumoconiosis. So let's see, Ram is an auto-mechanic. So which disease is more common in auto-mechanics? We are not sure, right? So let's see the examination first. So examination revealed calcified pleural plaques on imaging. So on a chest X-ray, it reveals calcified pleural plaques, or on a biopsy. So please remember, calcified pleural plaques are very much characteristic of which type of pneumoconiosis? So please remember, calcified pleural plaques are characteristic feature of your asbestosis. So please remember. So Ram का provisional diagnosis क्या हो गया? It is your asbestosis. Now moving on to Shyam. Shyam is a minor by profession, and which is the pneumoconiosis which is more common in minors? As we all know, it is your silicosis. But let's see if the findings are supporting our diagnosis or not. So he's a minor by profession, and his chest X-ray revealed eggshell calcification. Yes, very much important. The characteristic feature of silicosis on a chest X-ray is nothing but your eggshell calcification. Therefore, we have come to a diagnosis that Shyam is suffering from what? Shyam is suffering from silicosis. He is suffering from silicosis. Okay, we have the provisional diagnosis in mind now. So let's see which of the statement is not true. Shyam is more likely to develop tuberculosis. So please remember guys, Shyam is suffering from silicosis, and as we all know, silicosis ka most common association is what? tuberculosis. Therefore, it is sometimes also termed as silicotuberculosis. So please remember, yes, Shyam is more likely to develop tuberculosis. Yes, this statement is right. Next, option B. Ram's condition predisposes him to develop bronchogenic carcinoma. What is Ram suffering from? Asbestosis. And as we all know that asbestosis ka most common association are your lung tumors, and the most common lung tumor with which asbestosis is associated is your bronchogenic carcinoma or adenocarcinoma. Okay, so important one, bronchogenic carcinoma is the most common association, therefore Ram is predisposed to this. Okay, this is also a true statement. Next one, option C. Chest X-ray of Shyam will likely reveal snowstorm appearance. Okay, so as Shyam is suffering from silicosis, as we all know, a chest X-ray of silicosis patient would more likely reveal a snowstorm appearance. Okay, all the lungs would reveal some reticulonodular opacities. Okay, so like these. Okay, reticulonodular opacities would be seen in throughout the lung, and this is known or termed as your snowstorm appearance on a chest X-ray, which is characteristic of silicosis. Yes, this statement is also right. Now let's see option D. Progressive massive fibrosis is the most common association with Shyam's condition. Is it so? Is silicosis predisposing to progressive massive fibrosis? No. So please remember, progressive massive fibrosis, PMF, is more commonly associated with which type of pneumoconiosis? It is more commonly associated with anthracosis. Okay, cold workers pneumoconiosis, not with silicosis. So option D, that is progressive massive fibrosis is most common association with Shyam's condition, is the false statement. So now guys, let's discuss some important points about your pneumoconiosis. Okay, so this was a pretty large question, I know, but this is just for the sake of understanding that you can compare two conditions at the same time. Okay, if some question appears in the examination like this, you would be very confident to solve some such type of question. So let's discuss about pneumoconiosis. What are pneumoconiosis? Pneumoconiosis are nothing but your occupational lung diseases. Okay, occupational lung diseases which are associated with some exposure to some occupation or profession. So occupational lung diseases. So now the question can come from PSM also. The most common occupational lung disease. And what should be our answer? The most common occupational lung disease is your coal workers pneumoconiosis, also known as anthracosis. So please remember the answer to the question. The most common occupational lung disease or the most common type of pneumoconiosis is your coal workers pneumoconiosis, also known as anthracosis, which is usually seen in cases of coal mining industries. Okay, so it is usually seen in cases of coal miners. Okay, and the important points that are to be remembered for coal workers pneumoconiosis is that it progresses to progressive massive fibrosis. So please remember, important one, coal workers pneumoconiosis can further progress to progressive massive fibrosis. That is, the extensive lung involvement would be there, where the lungs would be fibrosed diffusely. Okay, that is seen in cases of anthracosis. Okay, important one. The important point that you need to remember again is your particle size. Okay, question has come earlier also from Patho also and from PSM also. The most important particle size which is responsible for causing occupational lung diseases. Okay, so the particle size is 1 to 5 microns. Important. Okay, so the particle size which is responsible for causing pneumoconiosis is 1 to 5 microns. Okay, so 1 to 5 microns of coal dust or silica dust is the most common one which can lead to these pneumoconiosis. Moving further to our next two important diagnosis that we had in our first question. These are two pneumoconiosis that are very much important, guys, and these two are your silicosis and asbestosis. Always compare them and read. Okay, that becomes very much important, easy then. Okay, so as the most important two differentiating features in silicosis, mainly upper lobes of the lungs are affected. Usually, please remember, usually in cases of silicosis the upper lobes of the lungs are affected, whereas in cases of asbestosis the lower lobes are predominantly affected. Upper lobes in silicosis, lower lobes in asbestosis. Easy. Next one, which are the professions with which silicosis is associated? So silicosis would mostly be seen in cases of exposure to silica, would be mostly in cases of sand blasting industries. It is seen in cases of sand blasting or glass cutting industries. It is seen in cases of sand blasting or glass cutting industries, or in cases of miners. Okay, these are the three important professions where silicosis is associated with. Then asbestosis is usually associated with cement industry or auto mechanics. Okay, so asbestosis is more commonly associated with cement industry workers or auto mechanics. Next feature that you need to remember, guys, the most dangerous fiber of silica which is responsible for silicosis. The most dangerous fiber of silica is what? It is your quartz silica. The most dangerous type of silica is your quartz silica. Whereas the question can come from asbestosis, that is the most pathogenic fiber of asbestos. And the most pathogenic fiber of asbestos is your amphosite or straight fibers. Okay, the most pathogenic are your amphosite, also known as your straight fibers. Okay, important one. Next question. The most common disease or infection which is associated with silicosis, and as we have already studied in the last question, the most common disease or infection associated with silicosis is what? Your tuberculosis. So please remember, it is also termed as sometimes silicotuberculosis. Okay, so please remember, most common disease associated with silicosis is TB, and the most common disease associated with asbestosis is what? Please remember, those are your lung tumors. Lung carcinoma is more commonly associated with asbestosis. And which is the most common lung cancer associated with asbestosis? The question. We usually tend to mark malignant mesothelioma. So please remember guys, malignant mesothelioma is not the answer. The most common lung carcinoma associated with asbestosis, and the answer is bronchogenic carcinoma. And the answer is bronchogenic carcinoma. Important one. Okay, bronchogenic carcinoma or adenocarcinoma, followed by malignant mesothelioma, so please remember, the most common association of asbestosis is not malignant mesothelioma, it is just normal adeno or bronchogenic carcinoma. Okay, important. If the question comes most specific lung cancer associated with asbestosis, then your answer should be malignant mesothelioma. If the question is most specific lung carcinoma associated with asbestosis, then the answer becomes malignant mesothelioma. Very good guys. Okay, now apart from this, now just see the markers. Okay, just remember the markers which are important. For bronchogenic carcinoma, the best marker is your napsin A. Okay, the best marker is napsin A, whereas for malignant mesothelioma, the best marker is calretinine. These are important questions from pathology that you guys need to know. And the last point that you need to know about these are your histopathological examination. As we know, if we perform a biopsy and we take it for histopathological examination, what are the findings seen? So in cases of silicosis, what can we see? We can see pleural thickening. Okay, in cases of silicosis, we can see pleural thickening along with interstitial fibrosis. These are the most important two features seen in cases of silicosis on a histopathological examination. On a chest x-ray, we have already studied, we can see two features. First is eggshell calcification, and second is what? Snowstorm appearance in cases of silicosis. But whereas in cases of asbestosis, what are the histopathological findings seen? So please remember, three important histopathological findings that you need to know. First are your pleural plaques, and as we have already discussed, pleural plaques are the most characteristic feature of asbestosis. Pleural plaques are the most characteristic histopathological feature of asbestosis. The next are your interstitial fibrosis. As I have already told, pneumoconiosis, all of them are RLDs, and most of the RLDs have interstitial fibrosis. And the last one, and the most important one rather, are your asbestos bodies. What are those? Your asbestos bodies, also known as your ferruginous bodies. Okay, so asbestos or ferruginous bodies, what are these? These are dumbbell shaped beaded bodies. Okay, along with iron. So iron is present, therefore they are known as ferruginous bodies. Okay, asbestos or ferruginous bodies in cases of histopathological examination of asbestosis. So these are the important features and the important diseases that you need to know guys. Okay, let's move on to our next question guys now. And the question states, a 60-year-old man presents with dyspnea and cough. Chest x-ray reveals irregular linear densities, particularly in both the lower lobes. Histopathological examination of lung biopsy is shown below. So this is your histopathological examination. This patient is most likely to develop. Okay, so let's see. 60-year-old man presents with dyspnea and cough. Chest x-ray reveals irregular linear densities. Okay, mostly where? In your lower lobes. So if we are talking about pneumoconiosis, which is the disease which commonly affects your lower lobes? Asbestosis, right? But our diagnosis is not yet confirmed. Let's confirm our diagnosis. The histopathological examination of lung biopsy is shown below. What is the histopathological examination showing over here? The histopathological examination is showing some bodies again. And what are these bodies? Dumbbell shaped beaded bodies. And what are these? Brown in color, so that is iron is present in these type of bodies. So these are your characteristic asbestos or ferruginous bodies. So please remember, this is a characteristic picture of your asbestos or ferruginous bodies present in cases of asbestosis on a lung biopsy. So what is a patient of asbestosis most likely to develop? That is our question, right? So a patient of asbestosis is most likely to develop which of the following disease? Option A is occupational asthma, option B is Centriacinar Emphysema, option C is tuberculosis, and option D is lung carcinoma. As we have already studied about asbestosis, we all know asbestosis patients are more likely to develop what? Yes, the most common disease associated with asbestosis are your option D, lung carcinoma, and the most common carcinoma associated with asbestosis is your bronchogenic or adenocarcinoma, followed by malignant mesothelioma, and most characteristic is malignant mesothelioma. Tuberculosis is most common disease associated with silicosis. Okay, important one, guys. Let's move further. Okay, these are the most important things that you need to remember about your occupational lung diseases. Okay, now a 42-year-old female presents to the OPD with complaints of cough, dyspnea, hemoptysis, and weight loss. Okay, bronchoscopy was suggestive of lung carcinoma. Lung biopsy was performed, which revealed the following picture. So this is a picture of your lung biopsy. Okay, histopathological examination. Which of the following lung carcinoma is the case likely suggestive of? So what is this case likely suggestive of? Let's see. Okay, so I would like, rather, before moving on to the actual question, we will just discuss the important points about your lung tumors first. Okay, so as we all know, lung tumors are very much important and they are confusing too at times. So just remember the important points in this revision. Okay, so first remember the most common lung tumors are what? In most of the organs, if they ask about the most common tumors, what should be your answer? So please remember the most common lung tumors should be secondaries or metastasis. So please remember the most common lung tumors are your secondaries or metastasis. Most common का आंसर most of the times यही होता है in most of the organs. Okay, so most common lung tumors are your secondaries or metastasis. If the question is the most common benign lung tumor in adults, okay, if they ask the most common benign lung tumor in adults, then your answer would be hematoma. Then your answer is hematoma. So please remember, most common benign lung tumor in adults is hematoma, and the most common benign lung tumor in children, and the answer would be inflammatory myofibroblastic tumor, and then the answer would be inflammatory myofibroblastic tumor. Okay, so please remember. What are the important points to be remembered about hematoma? So just remember, hematoma is usually considered a pseudo tumor. It is not considered an actual tumor. Why? Because the cells in hematoma are your normal cells. Okay, so they are not dysplastic or anaplastic cells. In cases of hematoma, there are normal cells. Just there is a haphazard arrangement of cells which is seen. Okay, so just there is disorganized arrangement. Of cells. Okay, normal cells but in a disorganized fashion or a haphazard pattern. Okay, so please remember, hematoma is the most common benign lung tumor in cases of adults. Okay, and one more point that you have come across many a times of hematoma, it is on a chest x-ray, hematoma will show which type of calcification? Yes, hematoma shows popcorn calcification. So important point. Okay, so hematoma, lung hematoma in cases of chest x-ray shows popcorn calcification. Two important points to be remembered from lung hematomas. The next question about inflammatory myofibroblastic tumor, which is the most common benign lung tumor in children. Okay, please remember the tumor marker for this, and that is ALK. Okay, so please remember inflammatory myofibroblastic tumor are ALK positive. ALK positive, that is anaplastic lymphoma kinase positive. Okay, so please remember the tumor for inflammatory myofibroblastic tumor is your ALK. Next one, if the question is most common lung malignancy, okay, most common lung malignancy worldwide, then your answer is adenocarcinoma. Most common lung malignancy worldwide is your adenocarcinoma. As we all know, adenocarcinoma is usually seen in whom? Adenocarcinoma is usually seen in non-smokers and mostly in females. So please remember, the most common lung malignancy in females is adenocarcinoma. Most common lung malignancy worldwide is adenocarcinoma. Most common lung malignancy in non-smokers is again adenocarcinoma. That is very much important, guys. Okay, and then next question, if they ask that is which is the most common lung malignancy in India, then your answer would be what? So please remember, in India the answer changes. As we know, in India there are a lot of smokers, So what happens during smoking, we have discussed in an earlier class of pathology in cell injury, where we were discussing about cellular adaptations. Due to smoking, what happens, there is metaplasia seen, okay, and that is the squamous metaplasia. The normal pseudo-stratified ciliated columnar epithelium of the respiratory tract now changes to a squamous epithelium, and this is squamous metaplasia, and which predisposes the individuals in India to develop which type of lung cancer? They develop squamous cell carcinoma. So please remember, the most common lung malignancy in India is your squamous cell carcinoma, which is very much common in males. Okay, lung carcinoma is very much common in males, as we all know. Okay, so important ones to be remembered. These are the important features that you need to remember. Now just let's see the lung malignancy classification that is widely accepted. Okay, so lung malignancies can be classified into two groups. First are your small cell carcinoma. And why small cell carcinoma is itself given a separate classification? Please remember, small cell carcinoma is very much important, and it has the worst prognosis out of all. Okay, so small cell carcinoma has the worst prognosis among all the lung malignancies, whereas the other ones would be classified as non-small cell carcinoma. Okay, other ones are classified as non-small cell carcinoma, and these are your squamous cell carcinoma, adenocarcinoma, and your large cell carcinoma. Out of all, which is the most common? Yes, adenocarcinoma is the most common malignancy worldwide. In India, it is your squamous cell carcinoma. Now let's discuss the important features about your adenocarcinoma. Two we have already discussed. It is most common lung malignancy in non-smokers and in females, whereas there is peripheral malignancy in cases of peripheral involvement. Okay, so peripheral or distal involvement of the lung is seen in cases of adenocarcinoma. Okay, important one. Then what would be seen on a biopsy? If we take a biopsy, as we all know, biopsies are diagnostic. Okay, investigation of choice for a lung cancer would be your biopsy. So if we perform a biopsy and see histopathological examination, what are the findings seen? So please remember, there would be atypical glands seen. Okay, as there is anaplasia, so atypical glands would be seen, along with N:2C ratio, which is increased. Okay, nucleus is to cytoplasmic ratio would be increased. Okay, nucleus would grow larger in size. Okay, so N:2C ratio would be increased. And which are the tumor markers? Important question again. Which are the important tumor markers for adenocarcinoma? The best tumor marker we have already discussed. For bronchogenic carcinoma or adenocarcinoma, it is the same. Okay, which is the best tumor marker for adenocarcinoma? It is your napsin A. The best tumor marker for adenocarcinoma is napsin A. The other one is TTF1. Okay, now we will also discuss about a special type of adenocarcinoma, and that is your bronchoalveolar carcinoma. Okay, the special type of adenocarcinoma is your bronchoalveolar carcinoma. Okay, it is also known as adenocarcinoma in situ. Okay, why it is known as adenocarcinoma in situ? So please remember, it is a non-invasive adenocarcinoma. Okay, it does not invade any of the further layers. It only affects your mucosa, and it grows along the mucosa. Okay, so please remember, bronchoalveolar carcinoma or adenocarcinoma in situ, which is also known as non-invasive adenocarcinoma. It does not invade or breach any of the underlying tissues. Therefore, it has which type of growth? It has your lipidic type of growth. Okay, it has lipidic growth, which grows only along the mucosa. Okay, important one. And it arises from which cells? It arises from your Clara cells. Okay, so adenocarcinoma in situ arises from Clara cells. Important point. And second, it never invades, it only grows in a lipidic fashion. So now let's see important let's go back to our question, guys, and see. Okay, so it is a 42-year-old female. Okay, so which is the lung malignancy common in females? It is your adenocarcinoma. We have come to a diagnosis that this is a case of adenocarcinoma. Let's discuss further. Complaints of cough, dyspnea, hemoptysis, weight loss. As we all know, hemoptysis is a very common complaint in cases of lung malignancies. Okay, weight loss. As we all know, cancer cachexias are very much common in cases of malignancies. Bronchoscopy was suggestive of lung carcinoma. Lung biopsy was performed, which revealed the following picture. And what is this following picture revealing? So please remember, the malignancies where the malignancy is only growing along the mucosa. So please remember, there is no invasion seen, there is no breach in the underlying tissue seen. So please remember, the malignancy is only growing along the mucosa. It is only growing along the mucosa. That means it is growing in a lipidic fashion. It is growing in a lipidic fashion. There is lipidic growth seen. So this is a classical example of what? This is a classical example of adenocarcinoma in situ, also known as bronchoalveolar carcinoma. And what have they asked in the question? Which of the following lung carcinoma is the case likely suggestive of? And the options are option A, adenocarcinoma, option B, squamous cell carcinoma, option C, small cell carcinoma, and option D, lung carcinoids. And the answer to this question is option A, adenocarcinoma. Okay, so if you know some points actually really well, then you can easily solve the questions. Okay, there is no issue in solving the questions. Moving further, guys, now to our next question. A 32-year-old chain smoker presented with persistent productive cough, fever, recurrent pulmonary infections. After his death, the lung specimen was extracted. Which of the following components are destroyed? Okay, so let's come to a provisional diagnosis at first. Okay, a 32-year-old chain smoker presented with persistent productive cough along with fever, along with recurrent pulmonary infection. So as we all know, this is a classical case of which disease? So this is a classical case of your bronchiectasis. This is a classical case of bronchiectasis. As we all know, in bronchiectasis, what happens? In bronchiectasis, there is abnormal and permanent damage. Okay, there is abnormal and permanent damage and dilatation. Okay, permanent damage and dilatation of what? Of your airways. So please remember, there is permanent damage of your airways, okay, or bronchi in cases of bronchiectasis. And bronchiectasis mainly presents with what? It usually presents with persistent productive cough. It presents with persistent productive cough, which is foul smelling. Okay, this is very much important. There is a foul smelling sputum. There is a foul smelling sputum, and foul smelling breath is known as what? Halitosis. So usually the patient presents with halitosis. There is foul smelling sputum in cases of bronchiectasis, and the patient is predisposed to recurrent pulmonary infection. Okay, repeatedly there would be pulmonary infections which would be seen in cases of bronchiectasis. Okay, important one. Along with this, there would be copious amount of sputum which is seen, and this excess or copious amount of sputum which is seen, it is known as bronchoria. This is known as bronchoria. Okay, so bronchoria, halitosis, foul smelling sputum, okay, and recurrent pulmonary infections is very much characteristic of bronchiectasis, where there is abnormal permanent damage and dilatation of your airways or your bronchi. Okay, now the lung specimen which is extracted will show destruction of what? In bronchiectasis, what are all destroyed? Option A, muscles, option B, elastic tissues, option C, cartilage, option D, all of the above. So please remember, muscles, elastic tissues along with cartilage, all would be destroyed in cases of bronchiectasis. Option D, all of the above, is your answer. So please remember, in cases of bronchiectasis, the muscles, elastic tissues, whereas cartilage, all are destroyed. Okay, as the elastic tissues, the elastase enzyme works on the elastic tissues, therefore they are damaged, and that causes the permanent dilatation of your airways. Okay, it is important. So please remember, these are the most important points that you need to know about bronchiectasis. Along with that, please remember, what is the investigation of choice? Investigation of choice your bronchiectasis is a HRCT chest. Okay, that is high resolution CT scan chest, which is the investigation of choice for bronchiectasis. On that, it would show the tram track appearance. Okay, so please remember, or tram track appearance or signet ring appearance is seen in cases of HRCT chest in cases of bronchiectasis. Okay, important one, guys. Okay, now let's move further to our next question. A 53-year-old man develops weakness, malaise, cough with bloody sputum, that is hemoptysis, night sweats. The chest X-ray revealed numerous apical densities bilaterally. दोनों lungs में there is involvement. Some of them are cavitatory. Okay, there are cavities formed in the lungs. There is history of tuberculosis in the family many years ago. Okay, so please remember, history taking is very much important, and there is a history of tuberculosis in his family. On sputum culture, Mycobacterium tuberculosis is identified, which is the basic underlying pathology. So now they are asking about the basic pathology in cases of tuberculosis, in cases of pulmonary tuberculosis. So before going on to the actual question, let's discuss important points about your tuberculosis, for starting with your pulmonary TB. Okay, as we all know, TB is a very common infection in India, therefore questions have been repeatedly asked, and you will see patients every other day in your OPD for your pulmonary TB or any other TB also. So please remember, what is pulmonary TB? Pulmonary tuberculosis is involvement of the lungs, and which part of the lungs is affected? As we all know, TB usually affects the apex of the lung. Okay, apex. As we all know, tuberculosis, Mycobacterium TB, is your aerophilic bacteria. It loves oxygen, therefore it is more commonly it more commonly affects your apex of the lung. Okay, so please remember, the apical lobes of the lung would be affected in cases of tuberculosis. Next important point that you need to remember are about the classical symptoms of tuberculosis. Okay, the question can become very much easy if you know the classical symptoms of tuberculosis. And what are the classical symptoms or signs of tuberculosis? Please remember, first one is your fever. Okay, and this fever, it actually rises in evening. Okay, so the fever has diurnal variations in cases of tuberculosis. First is your fever with diurnal variation. Second is your long standing cough, and this is the most important one. Okay, how we screen tuberculosis? We ask the patients who are suffering from long-standing cough to undergo screening test for TB. Okay, so long-standing cough is the most important classical symptom of your tuberculosis. So long-standing cough, which is lasting for usually more than 2 to 3 weeks, is characteristic of tuberculosis. Next one, anorexia, that is your loss of appetite, which is seen in cases of TB. Also we can see night sweats or night cries are seen. Okay, so night sweats or night cries, that's the patient experiences pain in night. Extreme pain is experienced in night. Okay, so night sweats or night cries are seen in cases of tuberculosis. Along with that, there is a significant weight loss. And what do we mean by significant weight loss? As we all know, significant weight loss is how much? Significant weight loss is more than 10% of weight loss over 6 months. So more than 10% of weight loss over 6 months is considered significant weight loss. Along with that, there would be generalized weakness, malaise, all these symptoms would be there. Okay, but these are the most important 5 classical symptoms of tuberculosis that you need to remember. If a patient of pulmonary tuberculosis comes to us with chronic cough, okay, what would be sent for diagnosis? As we all know, the first investigation that we will send is your sputum microscopic examination. We collect spot sample and early morning samples of sputum and we send it for microscopic examination. If sputum microscopic examination undergoes a Zeal-Nielsen staining, a ZN staining, okay, so what would be seen on a ZN staining? We can see 20% acid-fast bacilli. Okay, 20% acid-fast bacilli would be seen in cases of sputum microscopic examination under ZN stain. Then we can also send this sputum for what? Yes, we send the sputum for culture. So sputum culture is sent, and sputum culture is done with what? It is done with LJ media, that is Lowenstein-Jensen media. So LJ media is used for culture of sputum in tuberculosis. Okay, and the investigation of choice would be what? After all these screening tests, what is the investigation of choice? So please remember, the investigation of choice in cases of tuberculosis is your CB-NAT. And what is CB-NAT? That is your cartridge-based nucleic acid amplification test. Also, we can prefer gene expert assay. We can also prefer gene expert assay followed by line probe assay. Okay, so please remember, what are the investigation of choice? The most preferred one is your CB-NAT followed by gene expert followed by line probe assay. Okay, important ones. Then if we perform a histopathological examination, if we take a biopsy from bronchoscopy, if we take a biopsy and we perform a histopathological examination, what are the findings seen? The main classical finding of tuberculosis is what? The main classical finding of TB is your caseating granuloma. So this is very much important from pathology point of view. What is seen in tuberculosis? We can see caseating granuloma. So important one. Okay, so as we all know, granuloma we have already studied. Okay, so please remember, caseating means what? Caseating means cheesy or caseous necrosis is seen. So okay, please remember, at the center of the granuloma, what is seen? We can see cheesy or caseous necrosis, which is surrounded by the granuloma, that is your epithelioid cells, macrophages and your lymphocytic infiltrate. So please remember, in cases of tuberculosis, what is the basic histopathological finding? That is your caseating granuloma, in which at the center there is cheesy or caseous necrosis surrounded by a granuloma. Okay, important one, very important question. Okay, now let's discuss some few more points about TB that you need to know, guys. So in cases of children, usually in cases of children, pulmonary TB, okay, primary pulmonary TB would manifest as what? So the primary region of pulmonary TB is what? It is your Ghon's focus. The primary region of pulmonary TB in children is your Ghon's foci. Okay, Ghon's focus. If this Ghon's focus is involved along with lymph node, now Ghon's focus along with lymph node is there, then it is known as your Ghon's complex. Then this becomes your Ghon's complex. Now if this Ghon's complex is calcified, if this Ghon's complex undergoes calcification, then this would be known as your Ranke's complex. Then this is known as your Ranke's complex. Important one. Okay, these are the important features that you need to remember. Along with that, some more important questions that had come earlier from pulmonary tuberculosis or extrapulmonary TB. So let's discuss about them. the most common site for congenital tuberculosis. Okay, which is the most common organ or the most common site for congenital tuberculosis? So please remember, it is your liver. Okay, so liver is the most common site for congenital tuberculosis. Now they also ask about your lesions. Okay, so first of all, most common site for extrapulmonary tuberculosis. Which is the most common site of extrapulmonary tuberculosis? As we all know, the most common site for extrapulmonary tuberculosis is nothing else but your lymph nodes. So please remember, most common site for extrapulmonary TB is your lymph node, followed by pleura and followed by bones and joints. So please remember, the most common site for extrapulmonary TB is lymph nodes, followed by pleura, followed by bones or joints. And which is the most common bone affected? It is your lumbar vertebra. It is your lumbar vertebra. Please remember. Okay, port spine is usually seen in cases of extrapulmonary spread. Okay, this is important. Whereas some important features that you need to remember, guys, about the lesions. Okay, which is the lesion which is seen in CNS? If there is dissemination of your tuberculosis, and if there is lesion in the CNS, what is this lesion known as? So the lesion in CNS is known as Rich's focus. Okay, the lesion in CNS is known as Rich's focus. The supraclavicular lesion would be known as Puhl's lesion. Supraclavicular lesion is known as Puhl's lesion, and infraclavicular lesion would be known as Assman's focus. Okay, so please remember, infraclavicular lesion is known as Assman's focus, and supraclavicular is known as Puhl's focus or Puhl's lesion. These are the most important features, guys, that you need to remember about your tuberculosis. Okay, apart from that, if you send, okay, if pleura is affected, then there would be pleural effusion. If there is some gastrointestinal tuberculosis, there can be ascites. So in cases of pleural effusion or ascites, what we do, we perform a pleural or a ascitic tap, and then we obtain this fluid. And if we obtain this fluid, then we send it for different tests. Okay, and what are the tests that we send it for? So we send it for some biochemical tests and some microbiological test. Okay, so the important features which are seen in tubercular fluid, okay, a tubercular exudative fluid, which will show what? So some important features that you need to know. First of all, there would be elevated levels of LDH, that is lactate dehydrogenase levels would be elevated. Second point, proteins would be elevated. As we all know, if we also send CSF for analysis for a tubercular meningitis case, there would be elevated LDH, elevated proteins, there would be decreased sugars, that is glucose would be decreased in this fluid, and lastly, important one, ADA would be elevated. And what is ADA? ADA is your adenosine deaminase. So please remember, in any of the serous fluid, if adenosine deaminase is detected in elevated levels, that is very much suggestive of a tubercular pathology. So please remember, if any of the serous fluids is showing elevated ADA levels, that is very much suggestive of your tubercular etiology. So please remember, this is very much important to be remembered. Okay, whereas if we also send it for TLC, definitely TLC would be elevated, that is there would be leukocytosis, and in differential leukocyte count, it would show what? It would show lymphocytosis. As we all know, tuberculosis is a chronic infection, and we have discussed earlier, in chronic infection, which are the blood cells which are elevated, those are your lymphocytosis. So lymphocytosis would also be seen. Okay, important ones. So these are the most important features that you need to remember about pulmonary tuberculosis or extrapulmonary tuberculosis in cases of pathology. Moving on to our next question, guys. Before that, let's go to the question. A 53-year-old man develops weakness, malaise, cough with bloody sputum and night sweats. Okay, chest X-ray revealed numerous apical densities. As we have already seen, that apex is the most commonly affected part. Some of them are cavitatory. Yes, cavitation is usually seen in cases of TB. There is history of tuberculosis in family. So family history is very much important. There is contact with a positive case. On sputum culture, MTB is identified. Which is the basic underlying pathology? Option A, eosinophilic infiltration. As we all know, eosinophils were seen in the first question itself. That was some allergic etiology. So please remember, eosinophilic infiltration is usually seen in cases of bronchial asthma like conditions. Okay, or allergic conditions mein dikhta hai. Option B is caseating granuloma. And yes, option B, caseating granuloma is your right answer, which is the basic underlying pathology in cases of pulmonary tuberculosis. Option C, interstitial pneumonia. Option D, non-caseating granuloma. We'll be discussing about non-caseating granuloma in the next question. Okay, so let's move on to our next question, guys. Now, a 45-year-old patient undergoes liver transplant for cirrhosis developed due to alpha-1 antitrypsin deficiency. Which type of emphysema is this patient likely to develop? Okay, so as we all know, they are talking about emphysema, which is the most common emphysema associated with alpha-1 antitrypsin deficiency. Okay, so this is the actual question that these people are asking us. So let's discuss, guys, now. Okay, about emphysema. As we all know, COPD or chronic obstructive pulmonary disease has two components in it. First is your emphysema. It manifests as emphysema, or it can also manifest as your chronic bronchitis. So these are the most important two features of COPD. Okay, so either it would manifest as emphysema or it would manifest as chronic bronchitis. Okay, so what is emphysema? What happens in emphysema? There is irreversible damage and dilatation seen. Okay, same definition was seen where? Same definition was seen in bronchiectasis. Then what is the difference? In bronchiectasis, there was irreversible damage and dilatation of your airways, but over here there is irreversible damage and dilatation of your acini. So please remember, from respiratory bronchial onwards, all your alveolar ducts, okay, all your alveoli, they would be damaged and dilated in cases of emphysema. Okay, the lower respiratory tract is affected in cases of emphysema. This is the difference in both of these conditions. Whereas in chronic bronchitis, how it is diagnosed? Usually chronic bronchitis, it has a chronic cough. Okay, chronic productive cough is there mainly, which produces sputum. Okay, so there is a chronic productive cough which is lasting for more than 3 months, for 2 consecutive years. So please remember, chronic cough lasting for more than 3 months for 2 consecutive years is very much characteristic of which disease? It is characteristic of your chronic bronchitis. Now let's discuss, just remember 2 punchlines about emphysema and chronic bronchitis. How to diagnose a case of emphysema and chronic bronchitis, important in medicine too. So please remember, for emphysema you need to remember a tall, thin smoker. Okay, so please remember, both of these conditions or COPD overall is associated with smoking. Okay, so but emphysema is usually seen in tall and thin smokers, whereas chronic bronchitis is usually seen in short, obese smokers. Okay, so please remember, chronic bronchitis is usually seen in cases of obese smokers. Okay, these are the 2 punchlines. The question would start with these punchlines itself. Okay, most of the times. So emphysema, there is a tall, thin smoker. Chronic bronchitis, short, obese smoker would be there. Both of the conditions are associated with smoking. But what happens in emphysema? As there is smoking, okay, as there is smoking, what happens due to smoking? There is hypoxia. Okay, as the airways are damaged, hypoxia leads to stimulation of your erythropoietin production, and erythropoietin causes erythropoiesis. Okay, and excess of erythropoiesis causes polycythemia, and this polycythemia would lead to a pinkish appearance of the individual. Okay, and therefore the individuals of emphysema are known as pink puffers. The individuals of emphysema would be known as pink puffers, whereas in cases of chronic bronchitis, there is what? There is cyanosis seen. Okay, so please remember, there is no compensatory mechanism activated in cases of chronic bronchitis, therefore there is cyanosis seen. And as these are obese individuals, therefore the individuals of chronic bronchitis are known as your blue bloaters. Emphysema, pink puffers; chronic bronchitis, blue bloaters. Important one. Now let's further talk about your emphysema, because the question is focusing on emphysema. So let's discuss about the types of emphysema. There are different types of emphysema. The important ones are, let's discuss. First is your Centriacinar emphysema. Okay, so what happens in Centriacinar emphysema? Only and only the respiratory bronchioles are affected. In Centriacinar emphysema, only and only the respiratory bronchioles are affected. Okay, the next point, Centriacinar emphysema is the most common type of emphysema seen. So please remember, Centriacinar emphysema is the most common type of emphysema seen. And the third feature, that Centriacinar emphysema is most common emphysema associated with smoking. So please remember, which is the most common emphysema associated with smoking? It is your Centriacinar emphysema. First type. Second type is your Panacinar emphysema. Pan से क्या पता चलता है? Pan means all the alveoli are affected. Okay, there is diffuse involvement. Whole acini would be affected. Okay, whole acini would be affected in cases of Panacinar emphysema. And the important point, the association, Panacinar emphysema is usually seen in cases of alpha-1 antitrypsin deficiency. So please remember, the most common type of emphysema seen in cases of alpha-1 antitrypsin deficiency is your Panacinar emphysema, whereas the other types are your distal emphysema, where only the alveoli would be affected, irregular emphysema, and your paraseptal emphysema. Okay, these are your different types of emphysema. Now But the most important one, Centriacinar, which is the most common type, most commonly associated with smoking, and only respiratory bronchioles are affected. The second most common is a Panacinar emphysema, where whole acini would be affected, okay, and it is most commonly associated with alpha-1 antitrypsin deficiency. And the question asks us what? So the question asks us that the patient develops cirrhosis due to alpha-1 antitrypsin deficiency, and which is the type of emphysema would this patient likely to develop, okay. So please remember, as this patient is suffering from alpha-1 antitrypsin deficiency, the most common type of emphysema he would likely develop is option B, Panacinar emphysema, okay. Usually emphysema, the episodes of emphysema would be treated with oxygen, whereas exacerbation would be treated with steroids, okay. Important one. Now let's move on, guys, to our next question. Heart failure cells are seen in. So please remember, heart failure cells are seen in. What are heart failure cells? Usually what happens in cases of left ventricular failure, okay, when in cases of left ventricular failure, there is inability of the heart to pump the blood outside, okay. So the blood keeps on accumulating in the left side of the heart, and from there in the pulmonary circulation. So what happens in pulmonary circulation, as there is pulmonary arterial hypertension, there is extravasation of the fluid, and extravasation of fluid is known as what? Extravasation of fluid is known as edema. So it leads to pulmonary edema. So in cases of left ventricular failure, there would be pulmonary edema seen, okay. And pulmonary edema ke saath saath kya hota hai? There is extravasation of fluids along with RBCs, okay. There are also RBCs which are there, and these hemolyzed RBCs would lead to what? The hemolysis of RBCs would lead to release of iron, okay. So there would be iron stained macrophages, okay. There would be iron laden macrophages, okay, or hemosiderin laden macrophages. These would be characteristically known as. So please remember, there would be some hemosiderin laden macrophages, okay, due to the hemolysis of RBCs. Now this lysed RBC would release iron, okay, and this iron would be converted to hemosiderin, which is a pigment, and this hemosiderin would be taken up by what? Because as there is cleaning going on, phagocytosis is the function of whom? The phagocytosis is taken care by macrophages. So therefore these macrophages would engulf this hemosiderin, and these macrophages are known as hemosiderin laden macrophages, okay. They would be brownish in color, and these hemosiderin laden macrophages or brownish color cells are known as your heart failure cells, okay. These are known as your heart failure cells, and these heart failure cells are seen in cases of which condition? As we have already discussed, they are seen in cases of option A, pulmonary edema. They are seen in cases of option A, pulmonary edema. So please remember, guys, core pulmonary and pulmonary edema are very much important from medicine point of view also, okay. Please remember this. Moving further, guys, now the next question states, a person presented with complaints of primary infertility. He also complains of dyspnea, cough, and recurrent sinusitis. On chest x-ray, the cardiac shadow is on the right side. Which protein is defective in this condition? So let's see what is this case likely suggestive of, okay. So first of all, there is primary infertility, okay. He also complains of dyspnea, cough, and recurrent sinusitis. As we have seen, recurrent pulmonary infections along with dyspnea and cough, they are more likely suggestive of which disease? They are more likely suggestive of bronchiectasis, okay. They are more likely suggestive of bronchiectasis, okay. Important one. There is recurrent sinusitis, okay. This recurrent sinusitis is there. Recurrent sinusitis associated with bronchiectasis is usually seen in some condition, okay. Let's see what is this condition. And the third important feature that they are telling is your primary infertility. This patient is also suffering from, this male is also suffering from primary infertility, okay. And the last one, the feature is your what? It is your the heart is on the right side. The cardiac shadow on chest x-ray is seen where? It is on the right side. That is, there is dextrocardia, and dextrocardia when the organs are on the opposite side. This condition is usually known as what? This condition is known as situs inversus. This condition is known as situs inversus. So what is this picture suggestive of? So please remember this picture, these four diseases are likely suggestive of what? Cart-Jenner syndrome. This picture is likely suggestive of Cart-Jenner syndrome. And what happens in Cart-Jenner syndrome? There is bronchiectasis, there is primary ciliary dyskinesia, okay. What happens? There is some protein which is defective, okay, and this defective protein causes immotile cilia, and this immotile cilia would lead to impaired clearance of the sinuses, leading to recurrent sinusitis, and it will also lead to immotile sperms, leading to primary infertility. Okay, so this is a characteristic picture along with situs inversus, characteristic picture of Cart-Jenner syndrome. So please remember, Cart-Jenner syndrome is very much important, twice or thrice repeated question in your FMG examination. So please remember, which is the protein which is defective in this condition? This question also can come from physiology, applied physiology. So please remember, which is the protein responsible? Actin? No. Myosin? No. Kinesin? No. So please remember option D, dynein is the protein which is defective or which undergoes mutation in cases of Cart-Jenner syndrome. Okay, dynein is the protein which gives motility. Okay, so please remember, dynein is the protein which is defective in cases of Cart-Jenner syndrome. That is very much important, guys. Remember the triad that is bronchiectasis, recurrent sinusitis and situs inversus. This is the most characteristic triad. Okay, triad के features क्या क्या है? It is a bronchiectasis, recurrent sinusitis and situs inversus. Also, along with that, we can see primary infertility in some cases. Let's move on to our next question, guys. Now we'll be discussing about the next question, that is a 40-year-old female presented with cough, dyspnea and erythematous rash on the face. Okay, there is a erythematous rash on the face. On palpation, lymph nodes are enlarged. Chest X-ray shows bilateral hilar lymphadenopathy along with some pulmonary infiltrates. Histopathology shows Schumann bodies. Serum levels of calcium are high. Which among the following statement is false? So let's come to a provisional diagnosis first. Okay, there is a 40-year-old female, that is a middle-aged female is there. Okay, there is a middle-aged female. Okay, along with some respiratory complaints like cough, dyspnea and a characteristic erythematous rash is there on the face. Okay, so erythematous rash on the face is usually seen in cases of SLE, or it is also seen in cases of sarcoidosis. So let's come to a diagnosis first. On palpation, lymph nodes are enlarged. Chest X-ray shows bilateral hilar lymphadenopathy along with some pulmonary infiltrates. So with this, we can come to a diagnosis that this is a case of what? This is a case of sarcoidosis, because histopathology would also show Schumann bodies. Okay, so now let's discuss first few things about your sarcoidosis, which is very much important, but we tend to miss it because it usually is covered in rheumatology at times, but it is very much important. Okay, sarcoidosis में first feature क्या है? It usually affects middle-aged females, 30-40 age group females it affects. Okay, the most common age group affected is middle-aged females in sarcoidosis. Next feature to be remembered, it is a multi-system autoimmune disease. Okay, it is a multi-system autoimmune disease, that is autoantibodies are formed in this condition. Okay, and various systems are affected. Whereas they can ask you, then which is the most common organ or system affected in sarcoidosis? Then the most common system affected in sarcoidosis are your lungs or your respiratory system. Okay, so please remember, sarcoidosis is a multi-system disease, but the most common organ affected is your lungs. So what are the characteristic features? If we perform a chest X-ray, what are the characteristic features that would be seen in cases of sarcoidosis? We can see bilateral hilar lymphadenopathy. As you know, these are your lungs, for example, and this is your hilum, and the point at which your bronchial artery, your bronchus, primary bronchus enters the lung, that is your hilum. Okay, so what happens? The lymph nodes which are present in the hilum, they gets enlarged. Okay, so there is a bilateral hilar lymphadenopathy which is seen along with some pulmonary infiltrates. Along with some pulmonary infiltrates would be seen on your sarcoidosis. Okay, chest X-ray. Important one. Next one, if we perform a biopsy and if we perform a histopathological examination, what are the features seen? On histopathological examination, we can see non-caseating granuloma. We can see non-caseating granuloma on histopathology of your sarcoidosis, and this is very much important. Caseating granuloma with cheesy necrosis was seen in tuberculosis, whereas non-caseating granuloma is seen in cases of sarcoidosis and also in cases of hypersensitivity pneumonitis. Important features to be remembered. Non-caseating granuloma along with some interstitial fibrosis is also seen in cases of sarcoidosis. Okay, important one. Now, what is the important feature about this granuloma? So please remember, the non-caseating granuloma in cases of sarcoidosis is responsible for secreting one vitamin, and which is that vitamin? It secretes vitamin D. So please remember, vitamin D is secreted in excess by this non-caseating granuloma of sarcoidosis, and as we all know, what is the function of vitamin D? It causes increased calcium absorption. So as there is excess of calcium absorption, there would be hypercalcemia. Okay, as we all know, in the question also it was mentioned that there are high serum levels of calcium, so there is hypercalcemia due to this condition because the granuloma secretes excess of vitamin D, which increases calcium absorption. So hypercalcemia seen. Along with that, a very important feature that you need to know about your sarcoidosis, that in sarcoidosis one enzyme level is elevated, and which is that enzyme? ACE level is elevated. Please remember, angiotensin converting enzyme levels are increased in cases of sarcoidosis. As we all know, RAS, that is renin angiotensin aldosterone system, it is usually it usually takes place in your kidney, but the enzyme which converts angiotensin 1 to angiotensin 2, ACE, it is usually secreted where? In the lungs. This was the question. ACE is secreted where? In the lungs. Therefore ACE levels are increased in cases of sarcoidosis. Important one. Okay, then if we perform a lymph node biopsy, from the enlarged lymph nodes, what are we going to see? We can see conglomerates, calcified bodies. What are we going to see? We can see conglomerate calcified bodies, and these conglomerate calcified bodies are known what? These are known as Schumann bodies or asteroid bodies. These are known as Schumann or asteroid bodies. Okay, important one. These Schumann or asteroid bodies are seen in cases of sarcoidosis. Okay, so let's go back to the question now. So this is a case of what? This is a case of your sarcoidosis now. Okay, all features are there. Middle-aged female is affected. Cough, dyspnea is there. Erythematous rash on the face. What is this erythematous rash on the face? Please remember, in cases of sarcoidosis, there is a erythematous reddish color rash on the face, which involves the nasolabial folds also. The nasolabial folds are also involved, and that rash is known as lupus pernio. Which is seen in cases of sarcoidosis. Whereas in cases of SLE, there is a differential diagnosis SLE in which the rash which is seen on the face, it does not involve the nasolabial folds, and that is your malar rash or butterfly rash. Okay, this is different from the rash seen in SLE. This is your lupus pernio. Okay, so bilateral hilar lymphadenopathy is seen, pulmonary infiltrates are seen, Schumann bodies are seen, and serum levels of calcium are high, that is hypercalcemia is here. So this is for sure a case of sarcoidosis. Now, which among the following statement is false? So first option A, serum ACE levels are elevated. Yes, we have seen ACE levels would be elevated. CT scan shows a panda sign. Yes, please remember, CT scan or gallium-67 scan of sarcoidosis shows a panda sign. Then option C, the underlying pathology is caseating granuloma. Let's come back to this first. Option D, Kevin-Slid's back test is performed. Yes, Kevin-Slid's back test was performed earlier for sarcoidosis, but it is obsolete now. But anyways, this statement would term correct. So what is the wrong statement in this? Option C, the underlying pathology in cases of sarcoidosis is not caseating granuloma, rather than it is your non-caseating granuloma. Caseating granuloma was seen in cases of tuberculosis and not in sarcoidosis. Sarcoidosis where there is non-caseating granuloma. So therefore option C is the wrong statement. It is your answer. Next question. A patient came walking to the OPD with fever, tachypnea, chest retractions and dyspnea. The patient also complains of diarrhea and malaise. A chest X-ray ordered reveals interstitial infiltrate, and sputum examination is negative on gram stain, but only shows lymphocytic infiltrate. The most likely causative agent is, okay. So please remember guys, complaints of fever, tachypnea, chest retractions and dyspnea. This is a classical case or classical symptoms of what? Yes, these are classical symptoms of pneumonia. So please remember, we'll discuss some important points about your pneumonia. So this is a classical symptom of pneumonia. Okay, so what is pneumonia? Pneumonia is your infection of the pulmonary parenchyma. So it is also considered a restrictive lung disease where the pulmonary parenchyma would be affected. There is infection of pulmonary parenchyma with various organisms. Okay, the classical symptoms which are seen are what? They are your fever. Okay, there can be persistent fever. There would be rapid and shallow breathing, which is known as your tachypnea. There can be dyspnea, which is seen. Okay, so these are your characteristic features, and in children usually we can see chest wall retractions also, and also we can see grunting at times in children. Okay, so chest retractions are seen. Okay, if we perform a histopathology, what is seen on a histopathological examination? We can see only consolidation. Fluid is seen. Okay, so fluid would be seen in the lungs. There would be consolidation. Extravasated exudative fluid is usually seen in cases of pneumonia. Why exudative fluid? Because it is an infection. So in cases of infection or inflammation, there is exudative fluid seen, whereas in normal other conditions there is transudative fluid seen. Okay, important one. We'll discuss this in pleural effusion sometime later. So histopathological examination would show consolidation, and this consolidation on a chest X-ray would manifest as what? It would manifest as opacities. Okay, so whitish lung would be seen, whitish patches of lung wherever the consolidation is, in whichever lobe the consolidation is, there would be whitish patch. Okay, so depending on the involvement, pneumonia can be classified as lobar pneumonia when only one single lobe or one or two lobes of the lung are affected. Okay, that is known as your lobar pneumonia. It is a unilateral condition. Okay, only single lung would be affected. The second type would be bronchopneumonia. Okay, a bronchus is also affected. So bronchopneumonia is usually bilateral. Okay, so please remember, bronchopneumonia is usually bilateral. It spreads via the bronchus to the other lung also. So in bronchopneumonia, which is seen usually in extremes of ages, either in children or in elderly. Okay, what can be seen? We can see patchy consolidation. Here we can see a lobar consolidation, whereas in cases of bronchopneumonia we can see patchy consolidation. Okay, patches, whitish patches would be seen throughout the lung on a chest X-ray. Now, depending on the clinical presentation also, the pneumonia can be classified, and the clinical presentation of pneumonia can classify it as either typical pneumonia or atypical pneumonia. Typical or atypical pneumonia. So how typical and atypical pneumonia are classified? So please remember, typical pneumonia would be severe clinically. Okay, so clinical symptoms and signs would be more in cases of typical pneumonia, whereas atypical pneumonia would be mildly symptomatic or it would be completely asymptomatic. This is important. Okay, therefore it is known as your atypical pneumonia. Mildly symptomatic or asymptomatic, therefore the patient comes walking to you, therefore it is also known as walking pneumonia. Okay, then talking about your exudate differs. Okay, so please remember, exudation is seen where? In cases of typical pneumonia, exudation is seen usually in the alveoli. The exudate is found, the fluid is found in the alveoli. But as in cases of atypical pneumonia, the exudate is found in the interstitium. The exudate is found in the interstitium. So there is interstitial exudation in atypical pneumonia and alveolar exudation in typical pneumonia. Along with that, in this exudate, what can be found? Which cells can be found in typical pneumonia? In typical pneumonia, we can find neutrophils. Okay, please remember, in the alveolar exudate, whereas in interstitial exudate of atypical pneumonia, lymphocytes are more commonly found. Okay, we can find more commonly lymphocytes. These are the important features about typical and atypical pneumonia. We'll also study about the causes a few minutes later. Then, now going to your causes. Now, as we all know in medicine, pneumonia is also divided according to community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia. So let's discuss first of all, what is the most common cause of pneumonia? Most common cause of pneumonia or community acquired pneumonia, it is the same. Okay, so the most common cause of pneumonia overall or community acquired pneumonia is your pneumococcus. And what is pneumococcus also known as? Pneumococcus is also known as Streptococcus pneumoniae. So please remember, strep pneumonia is the most common cause of pneumonia worldwide. Okay, strep pneumonia is the most common cause of pneumonia worldwide. If they ask the most common cause of hospital acquired pneumonia, most common cause of hospital acquired pneumonia is your Staphylococcus aureus. Staph aureus is the most common cause of your hospital acquired pneumonia. Okay, important one. Most common cause of hospital acquired pneumonia is Staph aureus. Staph aureus is also the most common cause for your lung abscess. It is the most common cause for your lung abscess too. Which is the most common cause for ventilator associated pneumonia? So please remember, ventilator associated pneumonia ki most common cause is Pseudomonas followed by Acinetobacter. Okay, most common cause for ventilator associated pneumonia is Pseudomonas followed by Acinetobacter. Pseudomonas is also the most common cause for pneumonia in cases of burns. Okay, it is also the most common cause for pneumonia in cases of burns, in immunocompromised individuals, or in cases of cystic fibrosis. So please remember, in cases of cystic fibrosis, immunocompromised individuals, or burns, the most common cause of pneumonia would be your Pseudomonas. Important. Then, if a patient of pneumonia presents to you, but he is an alcoholic, so a alcoholic patient presents to you with symptoms of pneumonia along with red currant jelly sputum, okay, red currant jelly sputum is seen in this alcoholic pneumonia patient, then the most common cause for pneumonia would be Klebsiella pneumoniae. Important one. Okay, very important one. Okay, so alcoholic patient with pneumonia symptoms along with red current jelly sputum, Klebsiella pneumoniae. Okay, usually rusty sputum is seen in cases of pneumococcal infections. मतलब streptococcus pneumoniae के साथ जब pneumonia होता है, usually a rusty brown colored sputum is seen, but a red current jelly sputum is characteristic of Klebsiella pneumoniae in an alcoholic patient usually. Okay, and the most common cause of pneumonia and chronic bronchitis would be your Haemophilus influenza type B. Okay, important one. Which is the most common cause of atypical pneumonia? So please remember, most common cause of atypical pneumonia is your Mycoplasma pneumoniae. And what happens in Mycoplasma pneumoniae? Mycoplasma pneumoniae form some antibodies. Those are cold antibodies, and these cold antibodies are known as your Donat-Landsteiner antibodies. Okay, so please remember, Mycoplasma pneumoniae forms Donat-Landsteiner cold antibodies, which acts against your red blood cells, causing autoimmune hemolytic anemia. So a picture of pneumonia along with anemia comes to you, then that can be a case of Mycoplasma pneumoniae. Okay, it can be a case of atypical pneumonia. So please remember, most common cause of atypical pneumonia is your Mycoplasma. Other causes of atypical pneumonia. Atypical pneumonia can be caused due to various other causes like your chlamydia, your Pneumocystis carinii. Okay, Pneumocystis carinii or Girovacea is the most common cause of pneumonia in HIV positive individuals. Okay, as we all know, PCP, Pneumocystis carinii pneumonia, is the most common type of pneumonia seen in HIV positive individuals. This is a common question which has been repeated earlier. Okay, important one, guys. Okay, so please remember, other causes of atypical pneumonia apart from PCP or apart from Mycoplasma, there can be chlamydia, influenza, respiratory syncytial virus, measles, okay, Coxiella burnetii, which causes Q fever also. Okay, and also very important one, Legionella. Okay, also important one is Legionella pneumoniae. Okay, important one is this. So let's go to the question back now. Fever, tachypnea, chest retraction and dyspnea. So this is a case of pneumonia. The patient also complains of diarrhea and malaise. So have we seen diarrhea associated with pneumonia in any of the conditions? No yet. Okay, chest x-ray ordered reveal interstitial infiltrates. Interstitial infiltrates. Okay, important. Interstitium में infiltrate or exudates है. That is, it is a characteristic case of atypical pneumonia. Now we need to narrow down our thinking to atypical pneumonia. Sputum examination is negative on gram staining, okay, which is usually a case in atypical pneumonia, and shows lymphocytic infiltrate. Again, our diagnosis can be confirmed by this also. Usually lymphocytic infiltrate is seen in atypical pneumonia, neutrophilic infiltrate is seen in typical pneumonia. The most likely causative agent is now. So what we have seen, the most common cause of atypical pneumonia is Mycoplasma, but there is anemia seen along with it, not diarrhea. So please remember, diarrhea is usually seen in cases of Legionella pneumoniae. So if atypical pneumonia is caused by Legionella pneumonia, which is also known as Legionnaire's disease, okay, this condition is known as Legionnaire's disease, there is diarrhea associated with it. Okay, diarrhea and malaise are the common associations in Legionella pneumoniae. This condition is known as Legionnaire's disease, which is associated with continuous exposure to AC or humidified air. Which is associated with continuous exposure to AC or humidified air. Okay, so please remember, this is a characteristic example of Legionella pneumoniae. Option B. Okay, Legionella pneumoniae. Klebsiella pneumoniae in alcoholics. Mycoplasma pneumonia, most common cause of atypical pneumonia, but presents along with autoimmune hemolytic anemia also. And Streptococcus pneumoniae is the most common cause of pneumonia, typical pneumonia. Moving further, guys, just before moving further, I would like you to know that there are 4 stages of pneumonia, and this is very much important. Questions have been asked on this. There are 4 stages of pneumonia. First one is your consolidation. Okay, what happens in consolidation? There is just infiltration or exudation which is seen, fluid is seen. Okay, and neutrophils would be seen in cases of consolidation stage. Second is your red hepatization, and what is seen in red hepatization? Why the name is red hepatization? Because there are RBCs along with the fluid which is seen now. Okay, so RBCs along with fibrin would be seen in cases of red hepatization phase, which lasts for around 3 to 4 days. Okay, so in cases of consolidation there were neutrophils, in red hepatization there are RBCs along with fibrin. Third stage is your gray hepatization. Now what happens, that is the RBCs are hemolyzed, the color goes, the color fades away, there is only massive or extensive fibrin which is there, therefore there is extensive fibrosis which is seen, that causes gray hepatization. And last is your resolution. Okay, usually pneumonia resolves on itself, right? So please remember, the most common fate of pneumonia is resolution. This question has been asked multiple times. Most common fate of pneumonia is resolution, and in the resolution phase macrophages are seen to clear up all the debris now. Moving further, guys, now a neonate after a premature delivery experiences respiratory distress. There is a premature delivery, neonate experiences respiratory distress, and on general inspection, cyanosis is seen. All are treatment options below except. So a neonate who is delivered prematurely means less than 34 weeks period of gestation. Okay, so please remember, if a neonate is delivered before 34 weeks period of gestation, then it is considered a premature delivery. Okay, and usually, as we know, in cases of premature delivery, there is what? Inadequate surfactant production. Okay, what happens? Surfactant production is normally it completes around 34 weeks, but if the delivery is less than 34 weeks, then definitely in the fetus there would be inadequate surfactant, and if there is inadequate surfactant, what happens? The alveoli collapses because there is no proper surface tension maintained. So there is collapse of the alveoli, which causes this respiratory distress, and this is a classical example of what? This is a classical example of respiratory distress syndrome, also known as hyaline membrane disease. Okay, why it is known as hyaline membrane disease? Because as we know, if we take a lung biopsy of this child, on histopathological examination of respiratory distress syndrome, we can see hyaline membrane lining the alveoli. Okay, so please remember, a hyaline pinkish membrane is seen lining the alveoli all around. Okay, so it is seen on a biopsy of your hyaline membrane or respiratory distress syndrome. Okay, so hyaline membrane lining the alveoli all around, okay, would be seen along with some alveolar damage. Also we can see alveolar damage on a biopsy of your RDS. It is usually seen in premature infants. So please remember, not in term infants, it is usually seen in premature infants. Okay, it can also be seen in cases of infants of diabetic mothers, because in infants of diabetic mothers also there is inadequate surfactant production which is seen. Okay, inadequate surfactant production is seen in cases of infants of diabetic mothers also. What would be seen on a chest x-ray? So please remember, on a chest x-ray of respiratory distress syndrome or also ARDS, acute respiratory distress syndrome, the features of chest x-ray would remain same, and those are your ground glass opacities. What is seen? Ground glass opacities are seen. Okay, we can see white out lung, okay, or ground glass opacities bilateral in both the lungs would be seen. Whitish lung dikhta hai pure, okay, on chest x-rays of RDS or ARDS. They are also seen now in cases of what? In cases of COVID-19 also. Okay, so COVID-19 pneumonia would also manifest on chest x-ray as a ground glass opacity. Please remember, this is very much important, guys. Okay, and now apart from this, what are the treatment options now? What are the treatment options that can be given to this child? Option A, steroids to the mother prior to delivery. As we all know, steroids are given to accelerate the surfactant production. Okay, so to accelerate the surfactant production, steroids can be given to the mother prior to the delivery. This is your correct statement. Okay, we need to find the wrong statement now. So this is your dexamethasone or betamethasone are the drugs which are given usually to the mother. Next, option B, surfactant supplementation to the neonate is given. Yes, Axosur, Survanta are some of the surfactants which are supplemented to the neonate after birth. Okay, from outside. If the respiratory distress is so much that the baby cynos totally, the saturation level is falling persistently. Okay, in that case, surfactant supplementation is given. Option C, oxygen supplementation. Yes, definitely. If the patient is of respiratory distress syndrome, oxygen supplementation is totally required. Option D, bilateral lung lavage. No. So please remember, bilateral lung lavage is not done in cases of respiratory distress syndrome. It is rather considered in cases of neonatal pulmonary alveolar proteinosis. It is considered in cases of neonatal pulmonary alveolar proteinosis. Okay, so this is the usual condition of respiratory distress only, but usually seen in term infants. Okay, neonatal pulmonary alveolar proteinosis. In that condition, we perform a bilateral lung lavage. Okay, I hope respiratory distress syndrome is very much clear to you now, and you won't make any mistakes in pedia 2. Moving further, guys, now a 45-year-old male chronic smoker presents with dyspnea and hemoptysis. Okay, on HRCT, a well-differentiated mass was seen centrally, which shows keratin pulse on biopsy. The tumor markers P40 and P63 are elevated. The most common paraneoplastic syndrome implicated is. So first of all, we need to come to a diagnosis that which is this type of carcinoma seen, which is the type of carcinoma in this condition. Okay, so it is a 45-year-old male chronic smoker. सबसे important क्या है? It is a smoker. So which is the most common type of lung carcinoma in smokers? It is your squamous cell carcinoma. But let's see if our provisional diagnosis is supported by the other findings. It is squamous cell carcinoma. Let's see. Okay, there is dyspnea, hemoptysis, which is non-specific finding seen in all the lung cancers. On HRCT, a well-differentiated mass was seen. Okay, yes, well-differentiated mass is seen centrally. Adenocarcinoma is usually seen where? Peripherally. Centrally, it is your squamous cell carcinoma commonly seen. It shows keratin pearls on biopsy. Yes, a well-differentiated squamous cell carcinoma would show concentric lamellated rings, and those are known as your keratin pearls. The tumor markers P40 and P63 both are elevated, and these are the most important markers for your squamous cell carcinoma lung, P40 and P63. The most common paraneoplastic syndrome implicated as now. Let's see. So the diagnosis is confirmed, that is squamous cell carcinoma. Okay, important one. The diagnosis is squamous cell carcinoma, which is the paraneoplastic syndrome seen now. Let's see. Okay, so please remember, in cases of squamous cell carcinoma, what happens? Paraneoplastic syndromes are what? These are associated with malignancies. There is some substance which is secreted from the malignant cells, and this substance in the levels of these substance would be elevated. Okay, so in cases of squamous cell carcinoma, parathormone related peptide is secreted. What is parathormone related peptide? It is a protein which is secreted from the malignant cells of squamous cell carcinoma lung, which resembles parathormone. Okay, it acts like parathormone. And what does parathormone causes? Usually parathormone causes resorption of the bone, and it increases the serum levels of calcium. So parathormone causes usually hypercalcemia. So as this parathormone related peptide is secreted in excess by the malignant cells, what happens? There is resorption of bone, which causes elevated levels of calcium in blood, that leads to hypercalcemia. So please remember, the most common paraneoplastic syndrome implicated in cases of squamous cell carcinoma is your option A, hypercalcemia. What are the other options? For next option is your serotonin syndrome. Serotonin syndrome is also paraneoplastic syndrome, but it is associated with what? It is associated with your lung carcinoids. It is associated with which? It is associated with lung carcinoids, which is a neuroendocrine tumor. Please remember, lung carcinoids are your neuroendocrine tumor. Okay, and serotonin syndrome is seen. What happens with the lung carcinoids? The malignant cells in lung carcinoids, they secrete 5-hydroxytryptamine, which is your serotonin. So excess of serotonin is secreted, and that causes serotonin syndrome, which is manifested by what? Which is manifested by excessive vasodilation, leading to flushing and increasing gastric motility, that leads to diarrhea. So serotonin syndrome is manifested as flushing and diarrhea due to excess of serotonin secreted by the lung carcinoid malignant cells. Okay, now let's move on to the next one, SIDH and Cushing syndrome. So please remember, SIDH and Cushing syndrome both are the paraneoplastic syndromes associated with small cell carcinoma lung. Small cell carcinoma lung. So please remember, small cell carcinoma or oat cell carcinoma lung, it is the most common lung malignancy associated with your paraneoplastic syndrome. It is the most common lung malignancy associated with any of the paraneoplastic syndrome. So please remember, what are the paraneoplastic syndrome then seen with small cell carcinoma lung? Yes, first is your SIDS, that is syndrome of inappropriate ADS secretion. Excess of antidiuretic hormone is secreted. Okay, SIDH would be seen. Second is your Cushing syndrome. Cushing syndrome is due to excess of ACTH production. So this is ectopic ACTH, which is secreted by the malignant cells of small cell carcinoma, and that leads to Cushing syndrome. And the third most important paraneoplastic syndrome associated with small cell carcinoma lung is your Lambert-Eaton syndrome. Okay, it is your Lambert-Eaton syndrome. What is Lambert-Eaton syndrome? So please remember, Lambert-Eaton syndrome manifests as muscle weakness, and this muscle weakness is due to what? This muscle weakness is due to the antibodies which are formed against the presynaptic calcium channels. Okay, so what happens? There are antibodies formed against the presynaptic calcium channels, that leads to muscle weakness in cases of Lambert-Eaton syndrome, which is a paraneoplastic syndrome associated with small cell carcinoma lung. And lastly, what is that important feature that you need to remember about small cell carcinoma or lung carcinoids? Both of these are neuroendocrine tumors. So the best tumor marker which is associated with these are your chromogranin. Okay, please remember, the tumor marker associated with small cell carcinoma lung and lung carcinoids are chromogranin and synaptophysin. The third one is non-specific enolase also, but these two are the most important, chromogranin and synaptophysin. Okay, important ones. Please do remember this, don't forget this at any cost. Okay, then moving further, guys, now yes, with this I would like you to just go through some important points before completing my session. That is, Pancoast tumor. So please remember, Pancoast tumor, it is a tumor which usually is seen at the apex of the lung. Okay, it is usually seen at the apex of the lung, at the apical lobes. It is therefore also known as the superior sulcus tumor. It is also known as the superior sulcus tumor. Okay, it is a type of adenocarcinoma, and what happens, the mass of the Pancoast tumor usually compresses of the cervical sympathetic ganglia or the cervical sympathetic chain, and that can cause paralysis of the Muller's muscle, leading to Horner's syndrome. And as we all know, Horner's syndrome is manifested by what? You will study it in ophtha, don't worry. Horner's syndrome, in that we can see ptosis, meiosis, anophthalmos, anhidrosis, and loss of cerebrospinal reflex. Don't worry now, you will study it in ophtha again. So please remember, just remember that Pancoast tumor ke saath there is Horner's syndrome which is associated. Also we can see SVC syndrome. This mass can also compress the superior vena cava, leading to plethoric feces. There would be congestion of the face, plethora would be seen. Okay, and the last one, that is the gene mutations which are associated, please remember, with lung malignancies. So the question can be the most common gene mutation which is associated with all the malignancies of the body. Okay, with all the malignancies of the body, which is the most common gene mutation associated? It is your P53 gene mutation. It is your P53. Which is the most common gene mutation associated with lung malignancies? Which is the gene mutation associated with lung malignancies? It is your KRAS gene mutation. So the most common gene mutation associated with lung malignancies is your KRAS. Okay, other gene mutations can be epidermal growth factor 1, EGFR1, ALK, that is anaplastic lymphoma kinase, or CMYC gene mutation, which is LMYC gene mutation, which is usually seen in cases of small cell carcinoma lung. Okay, and the last question, that is most common site of lung metastasis. So please remember, most common site of lung metastasis is what? It is your adrenal glands. Okay, it is your adrenal followed by brain. Usually lungs are the most common site for metastasis for any of the primary malignancies in any other organ. But if they ask that is which is the most common site for lung metastasis, then the answer should be adrenals followed by brain. So with this, I come to the end of this session. Thank you so much. I hope this session has helped you. You have answered most of the questions right, and if not, please go through this revision properly. Okay, and yeah, let's meet in the next session very soon. All the very best from my side. Thank you so much, guys.